Okay, hello everyone. Good morning and welcome to today's specialty testing webinar. Our topic today is going off the gold standard, replacing gel electrophoresis with mass spectrometry. My name is Kayla Erickson. I'm a product manager for Mayo Clinic Laboratories. Our presenter today is Dr. David Murray. He's the assistant professor of clinical biochemistry and immunology at Mayo Clinic, Rochester. Just a couple of things to remind everyone before we get started today. There will be a question and answer session at the end of the program. You can submit questions via the online chat function throughout the presentation. If you are participating in the audio-only portion of this webinar, following the presentation, phone lines can be unmuted to ask any of your questions. Today's program is also being recorded and will be posted to our website in a few weeks. I'll now turn our discussion over to Dr. Murray.
Well, thank you, Kayla, and welcome to everyone who's out there listening. We're going to spend the next 45 minutes or so talking about work that has evolved over the last 5 years for the Protein Immunology Lab. And it's work that involves using mass spectrometry to replace gel electrophoresis, hence the title. Here are my disclosures. We have filed intellectual property rights on the mass spectroscopy part of this talk, and it has been licensed to an external company. So here are our learning objectives for today. First, I'd like to review the current testing that we do to detect these plasma cell disorders. This is so we all understand and are on the same page of what the gold standard has been. This is one area that the gold standard has remained for a very long time. And then we're going to transition into talking about how we can use immunoglobulin light chain mass distributions in order to detect these plasma cell diseases in a different way than we're currently doing with gel electrophoresis. And then I'd like to try to illustrate how we're using these assays here at Mayo in order to detect these diseases, and I'm going to do this through clinical presentations. So the disease that we're talking about today are the so-called plasma cell disorders, but I think they're better known here at Mayo as the monoclonal gammopathies. These are really diseases of plasma cells, and it's a whole host of range of plasma cell disorders, from dysregulation of the plasma cell to frank malignancy of the plasma cell. And so we're talking about a group of diseases here, from malignant, which is the dreaded multiple myeloma, which is the most feared of these diseases, to the benign, the monoclonal gammopathy of undetermined significance, to the rare, like amyloidosis, Pone syndrome, and now the new entity, monoclonal gammopathy of renal significance. But what all these diseases have in common is really the lab marker, the M protein. And the M protein is a very unique marker in clinical chemistry in that it's a marker that's really relative to another set of other immunoglobulins in the patient's serum. So what we're talking about here in terms of an M protein is the presence of a monoclonal immunoglobulin that's expressed above the polyclonal background in the serum of the patient. And I think this makes this a very unique and interesting set of diseases, because the detection of these is always relative to the patient's own polyclonal background, and I think this is very unique. Mayo Clinic has a long-standing history, a rich legacy of treating these diseases. This chart just shows the number of cases that have been treated here at the Mayo Clinic from 1960 to 2017. And you can see in terms of the types of diseases the monoclonal gammopathy of undetermined significance is by far the most common thing that we see here. But we've also seen lots of cases of multiple myeloma and AL amyloidosis. The other thing that this has also prompted for us is we also have a very rich serum bank. Dr. Robert Kyle, who defined a lot of these diseases, started banking these patient serums with patients that have these diseases, and we have a very rich history of biobanking that goes back into the 1960s. So it allows us to validate these kind of tests very quickly. So let's talk about the traditional markers that we use to detect M proteins, and this is what we're calling the gold standard. Well, serum protein electrophoresis is by far the longest standing and most utilized method in order to detect these M proteins. This just shows that the The graph in the middle, the figure in the middle just shows the typical result of a protein electrophoresis. So we take a agarose gel, which is shown here on the bottom. We put the patient's serum on in the middle. We add an electrical charge, which then causes the proteins to migrate based on their electrical charge. And then we add a dye to stain them. And then we take that gel and we run it through a light scanner and we create the figure that you see on top. The thing to point out here is this is using serum with it's not treated. It's straight serum, and so you see the fractions, the highest fraction being albumin, which is shown here, the alpha 1, the alpha 2, the beta, and then the gamma region. And in the gamma regions, this is where the majority of the immunoglobulins will migrate, although it's not uncommon to find monoclonal proteins that can migrate even under the beta region or even the alpha 2 region. And so we use this really as a screening method. These spikes mostly in this gamma region. This test has many benefits to it. First of all, it's really the only quantitative test for M proteins. It's relatively inexpensive compared to the other testing that we're going to talk about. And it's been well established. The serum protein electrophoresis has been around before even the FDA got to look at it, and so it's been grandfathered into the FDA, and we've been using serum protein electrophoresis here at Mayo since 1967. And it's really useful in detecting M proteins and to monitor patients over time. But it has some drawbacks also. One of the things is it lacks specificity. A restricted band in the gamma region can be due to other things other than a monoclonal protein. One that's very common is fibrinogen. So if the lab receives plasma instead of serum, fibrinogen will be present and can look like an M protein. With various levels, hemolysis can also cause peaks, mostly in between the alpha 2 and beta, that can be overinterpreted. We've seen cases where patients that have high rheumatoid factor, where that will glom on to some of the immunoglobulins in the patient's serum and cause a relative restriction and overcalling of an M spike. And IgG4 disease is another newly recognized entity that really shows up sometimes, looks almost like a restricted band within the SPEP and can be overcalled. And although it's quantitative, it has some limits to that quantitation. If you look at the International Myeloma Guidelines, they don't really recommend quantitating below 1 gram per deciliter, although there are many ways to kind of come around this, different integration techniques, but still it sort of struggles at those lower ends. And it also struggles at the higher end, as the M protein can only take on so much dye, and so the dye, the M protein peak will saturate with blue dye and you'll misquantitate. So it has some limitations in terms of quantitation. But it also has limited clinical sensitivity, and this is really due to the non-gamma migrating M proteins. IgA M proteins are notoriously suspect for migrating under the beta region, and they can be missed pretty easy on normal SPEP. And so to solve some of those problems of SPEP, immunofixation was developed. And this technique is, again, a gel-based technique where the patient's serum is placed on the gel 1, 2, 3, 4, 5, 6 times. The electrophoresis is done, and then we lay a mask over that gel. And on the top, we recreate the SPEP. And then on the other lanes, we fix the proteins that are IgG, IgA, IgM, kappa, and lambda. And then the band that's migrating on the SPEP can be positively identified by its isotype, both heavy and light chain. So the pros for this test in terms of detecting M proteins, that has high specificity, meaning that when I see a band and it immunofix, I know for sure it's an immunoglobulin and it's an M protein. It has higher analytical sensitivity because the washing away of the other proteins on the immunofix part will reveal some of the M proteins under the beta region and other proteins. And it provides isotype information. And that's important for clinicians. So isotype of an IgG and an IgA makes physicians think of myeloma, where an M thinks of LPL lymphoma or Waldenstrom's disease. And so this test is also used for screening and detection of low levels of M proteins and monitoring, especially when the M protein can no longer be seen on SPEP. But it also has a few cons. One is it's one of the higher cost methods that we have in the lab for detecting M proteins. It's very labor intensive. It's not quantitative. And so it has a role really in only detecting low-level disease and providing isotype information. Along the way, the free light chain assay was also developed, and this assay is a very unique assay, is that there are antibodies specific to detect free light chains in the patient's serum. What I'm showing you in the center is a normal intact immunoglobulin with its heavy chain in red, light chain in yellow, and all these plasma cells will make a slight excess of the light chain, and these light chains will circulate in the serum of a patient, and antibodies will be specific to detect epitopes that are only available for the antibodies when they're circulating as free light chains. This test has some pros also, and one, it's a quantitative test, so we can actually measure the level of circulating light chains. It can be done on automated equipment, and it has really high analytical sensitivity, especially for diseases that are associated with light chains. And it's useful for making diagnosis. It's now part of the diagnostic criteria for a set of smoldering myeloma patients, and you can use it to monitor and assess response in patients who have myeloma. But it also has some cons also. In some ways, it has lower specificity because the monoclonal protein isn't directly detected. It's really detected by looking at the ratio of kappa to lambda, and sometimes ratios can be out and not be a monoclonal protein. It has lower sensitivity for some of the diseases associated with intact monoclonal immunoglobulins, especially Waldenstrom's disease, and we'll show data on that in a little bit. But one of the things that we struggle with in the lab are the CVs on these kind of assays. So if you look, these are the types of coefficients of variations we get out of these tests that we use in the lab. SPEP we see is around 11% variation. IgG quantitation on an nephelometer around 14%. But you can see that the free light chain ratio has a high coefficient of variation, especially when you put it into a ratio. And therefore, sometimes you can get abnormal values that if you ran that again might not be abnormal. So it struggles a little bit in that regard. So in terms of using these tests currently as screening tests, our lab has looked into our data bank of patients, and we've kind of looked at how these tests perform individually. So what is shown here is the disease, MM standing for multiple myeloma, WM Waldenstrom's. These are the pre-malignant diseases, both Muggis and smoldering myeloma, and then primary amyloidosis. And if you just look at these tests individually, and that's what we're looking at here, and you're looking at the clinical sensitivity in a screening fashion, you can see that they all have strengths and they all have weaknesses. So if you look at myeloma, you would think that maybe serum immunofix should detect all of these, but a few of these patients will actually make what's called non-secretory plasma cells, meaning they don't make an M protein. So we don't detect those by normal electrophoretic methods. But some of those non-secretory patients will make abnormal free light chains, and so that's why the serum free light chain assay picks up most of the multiple myeloma patients. But if you look at Waldenstrom's disease, which is associated with an IgM of greater than 3 grams per deciliter, you can see that the serum free light chain is negative in a lot of those patients with really high disease. In terms of Muggis, IFE is the largest, has the best sensitivity for picking up Muggis. But in something like amyloidosis, which is associated with light chains themselves, you can see that the free light chain assay has its strength there. So this is why we ended up really with panels of testing for these diseases. It's because if you look at them in terms of panels, you can maximize the sensitivity of the screening. And so what is shown here are different panels that we examine serum protein electrophoresis, and just looking at cases where we see an abnormality and reflexing those to IFE versus running serum protein electrophoresis with a mandatory IFE after that, or running serum protein electrophoresis with just the free light chain ratio. But you can see that where the sensitivity is maximized in this assay is when you run a serum protein electrophoresis, IFE, and a serum free light chain. And you can see that this gives you the maximum sensitivity for detecting these diseases. And this is why the International Myeloma Working Group, when they put out guidelines, they recommend if you're going to look for some of these diseases and you want to maximize sensitivity, you should run serum protein electrophoresis, immunofixation, and a free light chain. And this should be sufficient for initial screening. However, in some diseases like AL amyloidosis, it's recommended that you also add urine immunofixation, because there are patients who will only show up positive in urine immunofixation. I'm going to show you a case of that later in this presentation. So now the question, why leave these gold standards? They've been in place since the 1960s in our lab. They have served a very good purpose, and they take care of patients very well. But what is changing, and why are we thinking of leaving the gold standard? One of the interesting things that we saw as I was a member of the College of American Pathology Diagnostic Immunology Resource Committee, we put out this question. We asked labs, what is the most common approach used by physicians who send samples to your laboratory to screen for the presence of a monoclonal immunoglobulin? And we gave them these choices. We had 741 labs respond to this, and what I have highlighted in F in the different color is the recommended guidelines from the International Myeloma Working Group. And surprisingly, or maybe not so surprisingly, you can see only 6% of the labs are actually following the guidelines. So what are most labs doing? Well, most labs are looking at serum protein electrophoresis, and if they detect an abnormality, then they'll send that to immunofixation. And we'll talk maybe why that is in just a little bit. Some labs only use serum protein electrophoresis. That would not really maximize your screening at all. Some labs are using serum protein electrophoresis and IFE together on every patient to screen. A few are going above and beyond. They're doing all three plus IgG quantitation. And then the rest are using different methods. So one of the questions we had to ask ourselves when we were trying to rewrite guidelines for the College of American Pathologists, so why are so many labs not following these guidelines? Well, maybe one of the questions that still lingers out there is, what is really the value that increased sensitivity brings to the screening? Or some people rephrase this, well, why should we find so many MGUSs since they're non-symptomatic? And one of the answers we have here at Mayo Clinic is that Paolo Merlini has defined this entity called small dangerous B-cell clones. These are diseases that are associated with very small M spikes. So at Mayo Clinic, we've recently defined a new disease or new entity of disease called monoclonal gammopathy of renal significance. These are patients who end up with renal disease but have very low levels of M proteins. AL amyloidosis, I'm going to show you a case about this, that it can present with very low M spike, undetectable by SPEP, and things like Poem syndrome. And what I'm showing you here is a case I love to show the residents, is primary systemic amyloidosis. This is a patient where we're looking at both the serum and the urine, and we're looking for the presence of a monoclonal protein. And what you'll notice in this is that you look at the serum, and these things don't project sometimes very well, but there's just barely a hint of a lambda light chain, a monoclonal lambda light chain in this serum. But when you go to urine, you can see that there's a problem with the urine, meaning there's too much protein in the patient's urine, meaning they're in renal failure. And if you look, there's just a very small little detection of a monoclonal lambda light chain. And these patients can go undetected for a long time. So increased sensitivity in detecting these diseases is needed in order to make the diagnosis, because if you don't find the M protein, you'll never think about this entity. The other thing that came up when we were writing the guidelines is many lab directors tell me that immunofixation may be too resource intensive. They say they just don't have enough resources in order to carry these guidelines out, because they're really labor intensive techniques. And we understand that very well. Here at Mayo, we're a high-volume reference laboratory. We're doing more than 750 of these tests per day. This is a picture of our lab. You can kind of see the technology, and those of you familiar with this, there's still a lot of manual pipetting in our lab. We have small batch sizes. We're using 9IF, so we're doing 9 patients at a time. We're screening them. And one of the things that we do for the Mayo practice is we love to try to keep our turnaround times within 1 day because we think that's good for patient care. And so we try to provide that. And so it's a very people resource intensive process for our lab. We also think it's good to read with history. This just shows a picture of our filing cabinets in our lab. In there are all the patients that we're following. And so there's a long process of tracking all these patients over time. Here you see Denise and Uma in our lab sitting. You can see sort of the process. You can see the gel sitting there with all their patient histories. And so it's very hard to keep scaling this up the way we were going. So one of the main drivers we saw for going off the gold standard for us was really improved workflow in the lab, and we'll get to that as we talk about the mass spec methods. But also multiple myeloma is changing. The disease is changing, and it's changing for the better. When these diseases were discovered in the 1940s, the only treatment we had was urethane, and the disease was universally fatal. Within 8 months, most patients were dead. But in the 1950s and 60s, we started to find some drugs that actually made some impact. We started to make some gains in overall survival, but still the majority of the patients, the disease never went away, meaning you would almost always detect M protein by current electrophoretic methods. In the 1980s, saw autologous stem cell transplant come in, and that really shifted the curve to where in the 1980s, 45% of the patients were getting to a 5-year survival. So that was really nice. But now in the 2010s and onwards, the discovery of monoclonal therapeutic antibodies has really pushed that curve quite a bit, fortunately for the patients. So now we're starting to see a significant increase in patients it's getting harder and harder to find residual disease in, and a lot of patients now in the lab who are treated with these, we don't detect the M protein anymore. So this presented some new challenges for the lab. First, using monoclonal antibodies to treat the disease when the monoclonal antibody is the measurement of the disease presents some challenges. And the fact that patients are going to lower and low levels of disease, this idea of minimal residual disease is starting to become a real thought in multiple myeloma. In fact, there are many people wondering if we shouldn't start treating patients to 0 MRD, and this is something that is just emerging in the field of myeloma. And really, current serum and urine electrophoretic methods are just not sensitive enough to classify these diseases out of serum. So attention has now changed to bone marrow, looking for MRD. And here at Mayo, the standard for care for us is this high sensitivity flow assay that we use to look at the bone marrow of treated myeloma patients for minimal residual disease. And this idea of therapeutic monoclonal antibody interference on gels is also a problem for the whole community. I'm just showing you here immunofixation for the common drugs that are now being tried in myeloma for cures. You can see daratumumab, isatuximab, elotuzumab, and although these are at higher levels than are used for treatment, but you can see they all are G-kappa drugs, and they show up on the immunofix gel just like a M protein, and they're causing some problems in trying to interpret whether the patient's still in remission or not, especially if the patient is a G-kappa producing myeloma. So this was another driver we sought out to do when we started looking for other methods. We wanted to know, can we increase the sensitivity of M protein detection in the serum? And how can we deal with these therapeutic monoclonal antibodies? So now we're going to transition into the methods. This is a summary of many methods that we tried. We've published these in the literature, and you can find them there if you want to look for them. And we've looked at many different methods, and this has been going on probably for the last 5 years in our lab. But they differ significantly in the fact that we're not using just straight serum anymore. We're actually purifying out the immunoglobulins before we start. This is what we found necessary to kind of increase the sensitivity of the assay. And so there are two main techniques out there that we've published in the literature. They sort of differ in their pre-analytical treatment of this immunoglobulin. In one of them, we just simply reduce the immunoglobulin into its light and heavy chain, as shown here on the top. We also looked at common proteomics methods where you actually use trypsin and you digest the immunoglobulin and you turn it into peptides. In the top method, what we're using for marker of disease is the intact light chain. So that's why that circle's around the intact light chain. On the bottom, we use tryptic peptides that came from the variable region of the immunoglobulin, and we were using those for markers to detect residual M protein. So we've made a few different applications of this, and what I'm showing here is as you go down these applications, they're increasing in the cost to perform the assay, increasing in the time and the complexity and sensitivity. So in the first method, which we're going to talk mostly about today, is using MALDI-TOF. We think that that has application for replacing serum protein electrophoresis and IFE. And in the literature, we've termed this mass fix. The other method we can use higher sensitivity mass spectrometers. They are more costly, but you can get better resolution, and we think these really have some role for minimal residual disease and therapeutic monoclonal antibody interferences, although the MALDI assay will also do that. And we call this MyRAM in the literature. And in the bottom, this is really, we published some of these results, but I think this is really basically a research method. I don't really see this being implemented into a high clinical lab. So for the rest of the talk now, we're going to focus on the top assay here using MALDI-TOF mass spectrometry. So here is the basic paradigm of how the assay works. So if you think about a plasma cell, the plasma cell is one of the few cells, or B cells in general, are one of the few cells that rearrange their DNA to make a very specific protein, and that specific protein is the unique immunoglobulin. So each plasma cell is making its unique immunoglobulin with unique amino acid sequence. And when I reduce those, like I showed, into the heavy and light chain, and I measure the mass of each of those, the light chain will have a particular mass and the heavy chain will have a particular mass. So now if I use that distinct mass as the marker or the fingerprint for the clone, then I can detect that immunoglobulin from that plasma cell. And if I look at the intensity of the peak, then that tells me how much of that immunoglobulin the plasma cell is making. So if you do this to normal human serum and you apply it and you just look at the mass distribution, you'll see that these light chains will separate themselves in mass space between the lambda and the kappa chains due to the difference in the constant region mass. But if you have a patient who's overexpressing one of these, as on the left that I just showed, and you can see an M spike, and you can see that that M spike on a very high resolution mass spectrometer is very unique, and you can even, so unique you can even pick up glycoforms of that M protein. So this is the basis. So it's very similar in some ways to serum protein electrophoresis in that we're looking for an overexpressed immunoglobulin. So how did we implement this? Well, we've worked on many different methods, but we thought the easiest way to bring this into the lab was to first replace the immunofixation. Although we can quantitate this and replace serum protein electrophoresis, the easiest entry that we thought for using this assay was to replace immunofixation. And so that's what we're going to be talking about today. So how does that work in the lab? So here's a typical traditional IFE, again, where you put the patient on here 6 times and then you fix with G, A, M, kappa, and lambda. We're doing something very similar on the mass spectrometer where we're immunopurifying with antibodies against G, A, M, kappa, and lambda. Then that gets spotted on a MALDI plate in 5 spectra. We collect those on a MALDI mass spectrometer, and then we overlay these spectra and looking for peaks. So if you look at a normal individual, this is our software that we designed to look at these. What I'm showing you here is that you get 5 spectra. You get a lambda, total lambda. This is in the blue, the total lambda that I'm pointing to. The total kappa here in pink. And then you get light chains specific that came off the heavy chain. So these are all the light chains associated with IgG. These are the light chains associated with IgA. And these are the light chains associated with IgM. And you can see that the kappa and lambda ratios reflect what you would expect to see for these isotypes. In IgG, you see almost a 1:2. IgA is near 1:1. And IgM is sort of 1.2:1. But if you do have an overexpressed immunoglobulin, like the patient here on the left, you can see that there is a peak that it looks very different than the normal. Here it's expressed in the pull down for the kappa and the IgG heavy chain, and so that's how we're isotyping. So in terms of the workflow in the lab, we've spent a lot of time working on this. We've put this into automated liquid handlers. So the patients get the serum tubes get placed in the automated liquid handler. It handles all the immunopurification. Out comes a 384 well ELISA type plate. We place that on a automated spotter, which then spots that onto multiplates for us, and then we run it on a Bruker Microflex, which is the same one used for bacterial biotyping. What we're going to show you here is just a quick video of a scan of one patient. What you're looking at here is the plate map where we put the patient on. Each one of these rows represents a patient where we're looking at IgG, IgA, IgM, kappa, and lambda. Up here in the top, you're going to see the video of the spot acquisition. And over here, you're seeing the actual real-time acquisition of the mass distribution. And you have to remember that in mass spectrometry, you get multiple charge. So over here are the light chains that pick up one charge. Here are the ones that pick up two charges. And down here are the patients that pick up three. So we're going to watch this video, and you'll just see the acquisition of one patient. So that we're moving here. You can see the laser is now acquiring spectra from the patient. And you can kind of already see, as we pointed out on the animation, we can already see the M spike in the IgG. Here is the IgA. You're seeing just the normal kappa to lambda ratio on the IgA. Now the heavy chains do ionize, but they don't ionize well. We don't get very good signal out of them because of their heavy glycosylation. Again, IgM is being collected now. And so now you see the kappa, and that kappa has the same M spike. And you're seeing the heavy chains here. And then we move to lambda, and there's not, and so that's the acquisition of one patient. So if you compare that to traditional electrophoresis of 15 to 20 minutes of electrophoresis, staining and scanning, you can see how it can improve the workflow for the lab. But along with that, we had to develop software, and I'm just showing you the in-house software that we designed. We spent a long time looking at this software. This allows us to keep positive patient identification throughout the process, which improves it for us in the lab, less chance of error. And one of the things that we really like is we're going to replace all those files are now being brought into electronic format. So this was part of the key of implementing this assay. This just shows what one run off our MALDI of the number of gels that we can replicate. And so for us, we can see that it's really decreased our labor in the lab. We've now collecting histories electronically. We don't need to use those filing cabinets anymore. We're keeping positive patient identification throughout, which is good for minimizing lab errors, decreasing repetitive motion for the techs in the lab, and we also have a new PLA code for this. So that's the benefits for the lab. What about benefit for the patient? And that's really what we care most about here. So we're going to talk a little bit about the analytical and clinical performance we've seen out of this assay. What I'm showing here is a set of 27 patients that we pulled who had M proteins in them. We selected to span the types of M proteins we see, so we used IgGs, A's, M, kappas, and lambdas. And then we took those M proteins and we started to dilute them into normal human serum to see where we could still detect the disease. And what this shows is the percentage of cases that we were able to detect. By definition, we detected all of them. They were all IFE positive in the beginning, and all those were also positive by our new mass fix method. But as you can see, as we dilute this into normal human serum, you can see the number of cases that blinded readers were able to call positive. And you can see at the 1 to 200 that the mass Immunofix is outperforming traditional IFE in terms of detecting minimal residual disease. This just shows one example for a patient that had an IgM. You can see the Immunofix over here, the dark band on the M and the kappa. This is the MassFix spectra for the IgM. And you can see as we dilute this into normal human serum at 1 to 100, it might be difficult to call that if you didn't have any history. 1 to 200 for certain you don't see it, but yet you can still see that peak in the mass spectrometer. So we do have increased analytical sensitivity. We also have what I believe is increased specificity, and I think this case sort of demonstrates what I mean by that. So this is a case that we used in the development of the assay. This was a 52-year-old man who came to us and had symptoms of amyloidosis. They did a fat biopsy and detected a lambda amyloid plaque in the patient's fat biopsy. Well, this patient came into the lab, and like I said, sometimes it's hard to detect the M protein in serum. We ended up calling a G-kappa, which was not consistent with the patient's lambda biopsy. So this prompted a call from the hematologist, said, "Are you really sure you're seeing G-kappa? Did you make a mistake?" So we thought, well, okay, this might be an interesting case to run on the mass spectrometer, so we ran it, and this just shows some of the increased sensitivity and specificity that you get. So what I'm showing on this spectra, which is an IgG pull down, what I've circled here is the G-kappa that we kind of detected by the gel. But there are other abnormalities on here that you can't appreciate on the gel. There's a G lambda that we didn't really appreciate. Here's some more G lambda, so this patient has multiple M proteins in them. But they have one here that doesn't seem to pair up with a heavy chain. So that looked like a lambda light chain that was present in the patient's serum. Well, eventually we did get urine, and as I said, sometimes urine is the only way you detect this. This happens to be one of the patients that was only detected in urine. So you can see on the IFE, here is the lambda that was picked up finally in the urine. And we run the urine by the same mass spec method, and you can see a very large peak for the lambda in the urine. But you can then use that mass, because it's the marker of the clone, to go back to the serum and say, yes, that's indeed the clone that we're looking for. And that's just not possible right now with current gels. One of the ways that we're using this is to really detect, is this G-kappa really a drug or not? So the question here is a G-kappa monoclonal protein in this, is this the drug or not? So knowing the mass of the drug allows us to positively identify it more than just by its isotype. So in our software, you can see we can highlight the mass range where we expect to find daratumumab. You can see in this patient, it's not daratumumab. We know that this is not the drug. However, in this patient who's being treated with daratumumab, you can see the G-kappa clone over here, which is the patient's M protein. And you can see the G-kappa from the drug falling within the mass range as we expected. So we figure by doing this method, we can positively identify the difference between drug and M protein in 80% of the patients with G-kappa. But there was some unexpected results that came along with this, and that is that while we were developing the assay, we started to notice patients who had monoclonal proteins that looked very monoclonal on the gel. When we put them on mass spectrometry, they had these very broad, high mass range peaks. What I'm showing you in this spectrum, in the red box that's outlined here, is the normal mass distribution for a light chain. But what we're seeing here is a very broad, high mass monoclonal protein. And through a lot of testing, we determined that these light chains are post-translationally modified with glycosylation. And what we found very interesting about this is that these seem to segregate into the disease AL amyloidosis. What I'm showing you here is a patient who has AL amyloidosis who has this broad mass range out here. Here's a typical myeloma patient with just a nice peak. You can see this glycosylated IgG kappa. And when we did a retrospective study through our database, we saw that patients with glycosylated light chains were 5 times more likely to have a diagnosis of AL amyloidosis. Overall, 17% of our patients who had AL amyloidosis had detectable glycosylation. And especially if it was a kappa, they were 13 more times likely to have AL amyloidosis. And what we did is to make sure, well, was that present before we detected the AL amyloidosis? And we were able to show that for all these patients, the glycosylated clone was still there when we were still diagnosing them as MUGUS. So that's really the story. So we now have this assay up and running. We have some assays now, some algorithms we've incorporated these into. They're now available through our testing catalog. The first one we're going to talk about is SMOGA, which stands for Screening Monoclonal Gammopathy Serum. We tried to simplify the testing. We believe that the best way to use this testing is that we're assuming that if you're screening for this, screening for an M protein, you don't already have a diagnosis of an M protein. So we think that this will be useful for primary care doctors. It's ordered according to the IMWG and CAP guidelines. So if you order SMOGA, you're going to get a serum protein electrophoresis, the new mass spec method, and free light chains to maximize the sensitivity of detection. And this will maximize the sensitivity of screening. It's currently what we use here at Mayo as our highest standard of care for patients. The second assay is we call MOMOGA, which is a monitoring monoclonal gammopathy serum. This really, we're assuming that you already have a diagnosis of either myeloma, MGUS, and the patient has an established M protein in their serum. And we set this up for resource utilization. And that's what we're trying to optimize here is for our patients and for our clients to optimize resource utilization. It doesn't include the free light chain assay because not all patients need to be monitored by that. So if your patient happens to be one who needs to be monitored, that will need to be added on to this. But what we do is we do a serum protein electrophoresis. If we can quantitate the M protein off of that, that's probably all we need because the diagnosis is already established. But if the patient's being treated and you want to find residual disease and we can't see it by SPEP, then we'll reflex it to our new mass spec test and give you those results. So we think that that will maximize resource utilization for our lab and for our clients. So just an update on where we stand on this. Our test went live in July 2018. We performed more than 10,000 assays, mostly for Mayo patients at this point. Our initial feedback from clinicians has been mostly positive. We are detecting more disease, but that was sort of what we knew would happen. We're now in the process of starting a second line in the lab so that we can improve our throughput and increase our ability to run samples. And we're really excited about continuing developments in this area. So with that, I think we'll go ahead and open it up for questions. I just want to thank the team. It was a really great team. There was a lot of effort put in by a lot of people. I'd just like to acknowledge the people in this slide. We have Mindy Cohen, who was the development tech who spent a lot of time developing this assay, Dr. Kyle, who was the founder of our lab, Dave Barnage, who contributed a lot to the mass spec work, Angela Dispenseri is a hematologist who kept us in line. Surrenda developed the software, and John did a lot of work for just hands-on work developing the assay as a fellow.
All right. Thank you, Dr. Murray. So at this time, we are open to take any questions that you may have. If you would like to ask a question, you can either submit that through the chat function, or for participants that are joining only in our audio portion of the webinar, press *7, and that will unmute your phone so you can ask your question. After you've finished your question, you can just press *6 to remute so that everybody can make sure that they hear. So I guess the first question that's out there, Dr. Murray, is knowing that we've made all of these changes and we've implemented this new test, what turnaround time are we giving to our patients and our clients with these tests?
So part of the thing that we like to maintain, at least for our in-house physicians and for our clients, is we like a one-day turnaround time. So we strive to get the majority of the samples out in 1 day.
I think that's really impressive because you're able to do the testing on that blood sample too. Has the clinic downtown found instances where they have made these detections on monitoring on those blood samples so that patients don't have to go to a bone marrow?
So it's something where we are looking at now. Some of the prospective studies that we're underway right now is to use this assay and to see how well it correlates with our flow MRD test that we have available. We have data on 150 patients, and we're in the process of analyzing this. And our hope as a patient care center is to maybe use the higher sensitivity to optimize when we do a bone marrow biopsy. I think there will always be a role after treatment to look at the bone marrow just to see how the cell lines are repopulating. and perhaps to do MRD, but we think that this test may, in the future, optimize when that bone marrow biopsy is taken.
All right. Do we have any questions from anybody who's on the webinar with us today? All right. Regarding patients where a monoclonal protein is found only in the urine, how many may have had some sort of nephrotic syndrome?
Well, that's one of the things that we kind of use in the lab and our clinicians use, is that if you see a monoclonal protein with a high albumin content, then that's a patient that's higher suspicion for AL amyloidosis, because the M protein could be related to the actual renal failure. The traditional Bench-Jones proteinuria, which we see often with myeloma, is a different situation. In that case, we see a high level of light chains in the urine, but we don't see the associated nephrotic syndrome that they're asking about. In those cases, we believe that that's sort of an overflow proteinuria, meaning the M protein is just overwhelming the kidney, and we're getting light chains in that. So it is an important clinical finding. In terms of our numbers, I don't have exact numbers of how often we see it, but it is true that if we see nephrotic syndrome and a monoclonal protein, that really raises the suspicions for AL amyloidosis, and now the new entity we call monoclonal gammopathy of renal significance.
Okay. Okay, so the question in response to that is, are you seeing these patients with monoclonal protein only in the urine but not in the serum who do not have that nephrotic syndrome? Are you able to separate them out?
Well, we are developing the urine test as we speak, and we are seeing anecdotal data. I don't have systematic data to actually back up what we're seeing, but we do see that in more of a case by case. But we don't have the studies need to be done in order to verify that in a more systematic fashion.
And I think that really brings up the conversation about this particular test and this new methodology. Is you've done a lot of work, but I think what you've also shown is there's a lot more work to be done and a lot more things to be found with how sensitive and specific this test really can be for these patients. All right, do we have any additional questions from our group? Okay then. If you have any additional questions, please make sure you indicate them on your evaluation form. It will be forwarded to you shortly after this presentation. Also, please remember that laboratory credit is extended for this program. Upon finalizing that evaluation, you have the option to claim that credit and print a certificate for your needs. As a reminder, this program was recorded. It will be archived and actually published on our website for review within a few weeks. What we'll also try to do is make sure we have some case studies as well available on how we're using these particular tests in the clinical setting at Mayo and what impact they've had to our patients. We can actually post a link to that conversation and those case studies as well. Thank you again for joining us today. We really appreciate your time.